One more non-cardiac cause would be GIT hemorrhage. Upper GIT hemorrhage. Now we talk about, sir, your answer. Myolysis. Okay, myolysis is nothing but splitting of muscles. Every time a person is coming in to the ED here with chest pain, we assume it is a myocardial infarction unless proved otherwise. And the first investigation that we are going to send is troponin. And if the troponin is elevated along with ECG changes, the treatment is started. Does that make sense? Like you would like to put this patient through an angiogram to see if the heart arteries are blocked or whatever. Does that make sense? Yeah? Now, hereafter, we're just going to concentrate on myocardial infarction and talking about how does troponin change in myocardial infarction. Okay? Infarction means cell necrosis. The cell is dead. Infarction is cell necrosis, implying the cell is dead. Myocardial infarction, because it is infarction and because there is cell necrosis, there is going to be release of troponin. And which two troponins are very specific for MI? It is troponin I and troponin T. Very, very specific for MI. Troponin I and troponin T. If they give you an MCQ and then they say choose one, troponin I or T, of the two, which is most specific for myocardial infarction? Troponin T. Yes, love it.
How long would elevated levels of troponin stay in the blood? Like how long?
I'm just going to answer that question. How does troponin increase? When does it peak? And when does it come back to baseline? Troponin levels start increasing in your blood after an MI from about 3 hours onwards. Levels of troponin will start increasing in your blood 3 hours after MI has happened. Okay? It will peak at about 12 hours. Peak at about 12 hours and remain elevated for about 7 to 10 days. So troponin starts increasing in your blood 3 hours after an MI. 12 hours it's going to peak and then starts coming to baseline 7 to 10 days. Late, somewhere between 7 to 10 days it's going to come and hit baseline. Clear? Now, this is very important to understand. If somebody is coming in with all signs and symptoms of MI, okay, and if you measure the troponin levels and the troponin levels are low, you cannot say that the patient doesn't have a myocardial infarction and ask them to go away. You will have to keep monitoring them for at least the next 12 to 24 hours. Does that make sense? Why? Because it's that if the patient has presented within 1 hour of an MI, the troponin levels are not going to be increased. Does that make sense? And that is why monitoring for the next 12 hours is a must. Does that make sense?
So would they always get someone with chest pain and overnight?
If we know the cause, like chest pain can have 20 or causes. So you will try to evaluate all the causes. But if you think that this is MI, and MI, let's say the past history of the person is he has had a myocardial infarction in the past. So that puts him at a higher risk and there is no other cause that you could figure out, I will keep him in. Okay? But if there is some other cause, we will treat that cause and let him go. Or send him to the wards, whatever. Does this make sense? Yeah? So that's what you need to know. Rate of rise of troponin, when does it peak and when does it come back to baseline? Perfect. So that's troponin for all of us. Now let's talk about liver function test. They every year have at least 2 or 3 questions in your exam about liver function test. What are the things that we measure whenever we have to assess somebody's liver functioning? We measure their bilirubin levels. we measure the liver enzymes, and which are the liver enzymes? AST, which is aspartate transaminase. It's also called SGOT, ALT, alanine transaminase. It's also called SGPT, ALP, alkaline phosphatase, and GGT, gamma glutamyl transpeptidase. Hence, these are the four most important liver enzymes: AST, ALT, ALP, and GGT. Then finally, we measure the serum bilirubin, albumin, and prothrombin time. Yeah, prothrombin time.
Time. What does that mean?
Can we talk about
Oh,
it
yeah,
when
yeah.
I come to it? Bilirubin levels. What is bilirubin and what does it do?
Is it the breakdown of the red blood cells products?
Beautiful. Hemoglobin, RBCs undergo cell death after 120 days. You know, right? 120 days is the lifespan of RBC. Where does it undergo cell death? It goes to the spleen where the RBCs are destroyed. Once the RBC is destroyed, hemoglobin is released from the RBC, and hemoglobin is then split into heme and globin. And this heme is then converted into bilirubin. Good. So hemoglobins break down into heme and globin, and heme is then converted to bilirubin. The type of bilirubin which is formed directly from heme is soluble. What is it? Is it soluble in water or insoluble? Do you know this? Have you covered this in PAD? You have, I'm sure, but you have forgotten. It's okay. Insoluble. Heme gets converted into bilirubin, and this bilirubin is insoluble. We call it unconjugated bilirubin or indirect bilirubin. Unconjugated bilirubin or indirect bilirubin is the insoluble bilirubin that is directly formed from hemoglobin. Everybody agrees? Now, if it is not soluble in blood, can it be excreted through the kidneys?
No.
It cannot be. Okay, so can I say that this unconjugated bilirubin, if nobody takes care of it, it's just going to keep building up in your blood, and building up of unconjugated bilirubin is considered dangerous because it can cross the blood-brain barrier and cause mental insufficiency. Does that make sense? Like in children, unconjugated bilirubin high can lead to kernicterus. Have you heard of this term? They can if a kid has high unconjugated bilirubin, it just means he's going to be he's got a very high risk of being mentally retarded. Good.
Sorry, Risha, what can cause it to build up again? Like, so if you've got
I have
kidney
not
failure-
discussed that. Hold
Okay.
on, Lily. I'll talk about it. Patience. Unconjugated or indirect bilirubin and insoluble bilirubin. Now, what happens to this? In order to prevent the buildup of unconjugated bilirubin, it's going to be taken into the liver. It's going to be taken into the liver where the liver enzyme UDP glucuronal transferase UDP glucuronal transferase acts acts on that unconjugated bilirubin and converts the unconjugated bilirubin into conjugated bilirubin. Conjugated bilirubin is direct bilirubin. Can I say it's going to be soluble bilirubin?
Yeah.
Beautiful. So unconjugated bilirubin taken up by the liver, metabolized with this enzyme called UDP glucuronide transferase, which converts unconjugated bilirubin into conjugated bilirubin. So can I say the process of conjugation happens in the liver?